Welcome to a webinar that Alice Fornari and Taranjeet Ahuja is part of the ICE and ACE Continuity Clinic program that we offer at the Hofstra, at the Zucker School of Medicine at Hofstra Northwell, our new name. And as part of the series that we do to develop faculty is offer webinars. We picked a topic tonight about, of course, something very dear to the heart of teaching and learning, which is collaborative feedback and the importance of collaborative feedback to all learners, be it medical students, be it residents, or even to junior faculty that you're working with. So tonight's presentation will be about collaborative feedback as a model. Oh, I have to do this. Okay. So the objectives are to understand collaborative feedback as a coaching and feedback model. Key steps, we're going to talk about a model that we use at the school, I'd say pretty religiously in terms of feedback, called SFED, and I'll go over that. Understanding about observable behaviors and the important role of self-assessment as a core feedback skill. So I'm sure many of you are familiar with Atul Gawande. And actually, this term coaching, it's not that he has developed the term coaching, but he certainly embodies it as a physician. And he states no matter how well trained people are, few can sustain their best performance on their own. And that's where coaching comes in. So he wrote this amazing article that was published in the New Yorker magazine about the importance of having coaches. And we know that coaches exist in musicians have coaches, athletes have coaches, chess players have coaches, many professions use coaches. And there's a big question, why doesn't medicine have a coaching culture? And the importance of coaching as a culture to continue to work at the highest level possible. And Atul Gawande has basically allowed people or brought people into his OR, he's a neurosurgeon, to look at his surgeries, even though he's considered very skilled, and to coach him about his surgeries. So this concept of coaching is across the spectrum of learners, even somebody as advanced as Atul Gawande. I forgot to mention that if you have any questions, you can type them into the question box that is on the screen. And at the end of the session, we'll answer all questions that are asked. And that would be important. So if you think of questions along the way, just type them into this question box. So according to Atul Gawande, the coach provides a skill set of ears and eyes on the outside perspective of performance. So this idea that a coach is watching somebody do something and looks with their eyes, it's direct observation. So one of the most important things about feedback to somebody is directly observing them. And this comes from the literature, and I'm bringing up Atul Gawande because he is a surgeon, a neurosurgeon, very prominent in the field of medicine. And this is what he is saying a coach does for you. And this person has to have credibility, creativity, and problem solving, be an effective communicator, and understand what it makes to be successful. And these small things come together like a puzzle to make the difference between somebody who's a good performer versus somebody who's great. So we'd like all our learners to be great. So each one of you who are in the ability to directly observe learners, be it medical students, as I said, residents, or junior faculty, or even more senior faculty, you need to use all your skills to help people go from good to great. But one thing that's so important is that there's humility and belief that people can engage in this work of getting better through coaching. So people have to be vested in this process. So when you think about being a learner, there's knowledge, skills, and attitudes. Those are the three core things we always talk about for learners. We want to give feedback on knowledge, we want to give feedback on skills, and we want to give feedback on attitude. This is basic principles of what to base your feedback on. And once again, it's really important that you build confidence in your learners. So you think about ability and skill, and if we go back to Atul Gawande, he's somebody truly skilled. He has ability, and it's also important that he has confidence in what he's doing. So when you have a younger learner who needs coaching, you want to make sure that their ability and skill and confidence are aligned, just like these two arrows are perfectly aligned. You want to align confidence with ability and skill. And it's your job to do that as the person giving feedback. So when you think about all the things required to be an effective teacher, what we're really focusing on today is assessing somebody and giving them the feedback, the coaching, and inspiring and being a role model to the people that you're working with. So when you do decide to give somebody some coaching or feedback, you want to inspire them and make sure that you're a role model for what you're talking about. So why do we care about feedback? And then if we care about it, are we doing it right? Because things that you care about, you want to do right. So feedback in this little image here that's on the screen shows that it's a dialogue between two people. So one of the biggest hindrance to good feedback is when it's not a dialogue and it's more of a monologue. So when we think about feedback, it's providing information to learners about clinical performance that guides their future clinical performance. So it's a dialogue between two people. Once again, the little table image here that you see has two people at the table, and one person is providing factual feedback to help the learner improve their performance for the future. This has to be very, very collaborative, back and forth, like this image portrays. So one of my most favorite articles on feedback, I really feel this is a gift to the medical education literature, is an article from Cheerleader to Coach, the development progression of bedside teachers in giving feedback to early learners. The thing that caught my eye when this was published in Academic Medicine, it was actually in November 2 years ago, was that it said from cheerleader to coach. So right away, it was aligning feedback with the coaching model that we're proposing. And this idea that you want to take people from a cheerleader to a coach. So very nicely in this article, they talked about the characteristics of less experienced teachers who are cheerleaders and the more experienced teachers who are coaches. So when we think about a cheerleader, it's somebody who really struggles giving negative feedback and they're focused on the positive. Now, we do want to focus on the positive, but we also want to focus on areas of improvement. Their feedback is very, very general and non-specific. And then if you get into the coaching model, the person who's a coach is able to be honest, very transparent with their feedback, so it's very clear to the learner. It's specific, directed, and targeted. So when you think about going from a cheerleader, I don't know how you'd characterize yourself, and maybe we could have this discussion at the end of the presentation. Are you more of a cheerleader or are you more of a coach? And if you're a coach, that's great, but if you feel you're just a cheerleader cheering somebody on, you want to move to this coaching model. They talk about being passive versus somebody who's a more experienced person, in collaborative feedback is very, very calibrated in their role of teaching. They're not passive. They're concerned about their students or their learners' fragility, but you also want to build resilience. Building resilience gets into the slide of building confidence. When you build confidence, you build resilience. You don't want the environment to be so easy that it's so safe that the student is not activated. You want to create a challenging and safe environment for your learners. And you want to have very strategic language for giving feedback. have clear goals and expectations, which is just a very important part of good teaching, and you really, really want to address specific behaviors for skill building, not personality traits. And know what skills students should have at different stages of development. And when I say students, I also mean residents. So what a PGY1 resident can do is different than a 2 and a 3. And when you have an MS1 student in ICE versus an MS2 student in ICE versus an MS3 student in ACE, each of those people have a different developmental trajectory. So your feedback has to be guided to that developmental trajectory. And most important, that when you give feedback to somebody, if it's very important that you understand what their peers or patients feel about them, you also want to gather that information. To simplify what they were trying to say in this sense, they said here in this diagram from the same article, basically, the approach to giving feedback is coaching, not cheerleading. The environment is safe. The delivery can be team feedback, meaning you get information from multiple sources. It's developmental. It's very calibrated to the learner. It builds resistance. It doesn't make them feel fragile. It builds resistance. And it's very strategic and goal-oriented. So the other diagram is a little more detailed. If you just remember this in terms of feedback, this is the most important. So this is the normal trajectory of feedback. You observe something, you mentally form a judgment. Many times the forms that people complete have a numerical rating of like 1 to 5 or 7, and you come up with a rating, and then you give feedback to the learner based on the factual information that you observed and formed a judgment on. One of the biggest problems, though, is many times you have to give the rating and the feedback without the observation. So your judgment is off because you did not have the observation of direct seeing what somebody has done. So if you get into that situation where someone says, please tell me how this learner did, and you did not observe them, your rating of them is going to be not accurate, and your feedback is not going to be accurate. So direct observation is the starting point of any feedback. So if we get into exactly how to do this, we want to teach people to look in the mirror and self-assess themselves. So the performance improvement that you achieve of leveling out this sort of seesaw picture comes from a self-assessment starting point, allowing people to look in the mirror and say, what is happening with my knowledge, skills, and attitudes? Your role as the feedback coach is to say, is the self-assessment reliable? Is this learner really seeing what needs to be seen? So you're a calibrator as the feedback person to make sure the self-assessment data is reliable. So this is the old feedback sandwich we used to talk about. I call it the Oreo cookie. And it used to be positive, negative, and positive. That was the way we did feedback for years and years and years. The new model is positive, collaborative feedback, and then leaving with direction, which is the coaching model that we're talking about. And this works so much better because, yes, you start with positive feedback. That's the confidence building of this process. But if you go to negative and then you have to go back to positive, many times it's hard to think of that second positive because you already used it up on the first positive. Here, you don't have to think of a second positive. You start with positive. Collaboratively, you discuss the facts of everything, and you leave with direction and coaching. Okay. So in this collaborative model, the SFED model, we're going to call it, we're going to go over what that means. Faculty solicit feedback from the learner first to level the playing field and make sure it's a bi-directional communication. So the way it works, the 4 components of this is self-assessment. The first thing you do is you allow the learner to self-assess and reflect on how they did in whatever the situation is. After the learner does that, you have the opportunity to describe what you saw. This is the factual feedback, but it's what you observed. So it's not what you heard somebody else say. It's not hearsay. It's nothing that you did not see and you did not hear yourself. The learner is much likely to accept this direct feedback of facts if you saw them and as well as after they've self-assessed. And there's a very good chance that the learner in their self-assessment will say the things you saw on observation, and it will ease the process of you giving feedback because they have already said it. Then you start with your personal reaction of coaching to coach somebody along. And the coaching comes through direction and encouragement. So the direction piece is helping the learner very specifically how they can improve with very specific directions. We all use GPS today to get places. The directions on GPS are very, very specific. For each turn, for how long the turn is going to be in front of you, very specific. So your direction and your coaching of your learner has to be that specific. But the last thing you do is sort of the icing on the cake, the little bit of sugar or honey or agave, whatever sweetener you like, and you use encouragement that the learner is going to be able to improve. And that's another job that a coach does, is they encourage their learners. Generally, the direction comes first, and then you end with the encouragement, and that's ending with the words of inspiration. And that's important. On occasion, if you have a very overconfident learner, and this does happen with our learners, very overly confident, maybe a little inappropriately overly confident, you might want to end with the direction piece so they really hear it if they're overly confident. But generally we end with encouragement. But if you have a very overly confident learner, you might want to switch the order and end with the direction piece. That's very specific and very concrete. Dr. Ahuja and I want to role play these steps so you could see them very clearly in a few minutes, or hear them very clearly, I should say. So in this model, self-assessment is step 1, acknowledges the difficult affective component of this. Self-assessment helps the learner own the feedback and be accountable for their behavior. So it's accountability of the learner. It's a skill for the learner to practice. It doesn't come naturally. They need to do this over and over. And luckily, this feedback model we use in the MS1 year, the MS2 year, the MS3 year. So by the time they finish medical school, they're very comfortable with this model. And it really allows them to be at a metacognitive level of reflection to recognize, receive, and respond to feedback. One of the things people always say is, the learners, they don't know how to respond to feedback. And the reason is because you haven't given them the opportunity to self-assess and acknowledge what they think about what they did. And then they can respond and receive the feedback because they've gone through that process. So the first step, it's very nice to say to the learner, you're looking in the mirror here. You see this little image here. So how did you think you did? What was your impression of your performance just now? How do you think your interaction with that nurse went if you're looking at something with professionalism? Tell me what you think about what just happened, maybe with a patient encounter. So it's a total self-assessment by the learner. Step 2 is the facts. I'm sure many of you have been in this sign where you see this bright sign at you, you're speeding 61 miles per hour, or speed limit is 40 and you're going 60. Signs like this, automatically, I'd say, I can't say 100%, most people will put their foot on the brake and slow up, no matter what. It's a reality check of a fact. Someone has measured your speed against the speed limit. Very factual information is step 2. So it's exactly what you will have observed in your learner. Then you do steps 3 and 4 with encouragement, coaching, and direction. I put up this image of all these intertwining circles here going back and forth because it is a process of encouragement, direction, and coaching, and it's not a linear process. Before we go to the role plays, can we see if there's any questions? I just gave you a ton of information, and I wondered if anybody had any questions to ask. Give them a second. Yeah, go ahead. Of course.
This is Taranjeet. So we're just waiting to see if anybody has any questions. But I also wanted to say that timely feedback is important, and that sign that Dr. Fornari showed you with the speeding sign, it tells you in the moment, and in the moment, hopefully your foot goes on the brake, and you remember, rather than getting a ticket months later about, oh, you were speeding in this zone, this date, you can't even recall where you were going. So it may not be as effective as it is in the moment and timely. So I think that's one part that I wanted to add to what Dr. Fornari was saying.
I think that's an excellent point, and that's why that sign works. And if you delay feedback in any way, the impact of it on the person owning it is where it's not evident. So I don't see any questions. So Dr. Ahuja and I are going to do a role play now. We're putting them up. And we want to demonstrate the steps that I just went over. I'm going to be the faculty member, and Dr. Ahuja is going to be our medical student at this point. This will be an example of either ICE or ACE. This could happen. It really doesn't matter. And for the people on the call that maybe work with residents, it would be the same idea. We did set it up in an outpatient office because of its ICE and ACE, but certainly things could be related back to the inpatient setting as well. So, Taranjeet, I wanted to bring you in. I noticed you canceled on a few of my ICE sessions that we've had scheduled the last few weeks. And last week, I think you called me the day of the session and canceled. I just wanted some idea of what's been going on because I really didn't expect this behavior.
Dr. Fornari, I'm really sorry. I have to be honest. I've been so overwhelmed with schoolwork that, I think I can make a session, and then the day of I realize I still have to do all my pre-reading for structure and the case-based learning class that I have, Pearls, and I just got so overwhelmed that I had to cancel on you, and I'm so sorry. I'm so behind work at this point.
Have you ever thought about how an erratic schedule, impacts this office and the patient care here? Have you ever thought about that? I know you're very involved in your studies, and I was a medical student, so I certainly, even though it's a while ago, remember the intensity of studying. Maybe the studying's a little different today, but you're coming to a professional office, and everybody who's supposed to be here impacts the patients and how the office runs. So if suddenly you're not here, do you ever think like what that call will do for the office?
I honestly didn't think about it. I didn't think I was that important. I thought, I'll just come another day. I honestly didn't think about it like that.
It's interesting because I remember feeling as a medical student maybe not that important, and you're thinking you're not so important is maybe a natural response. Here you are sort of thinking I'm low man on the totem pole. Nobody's going to know if I'm not there today. But it's very important. One of the things they've told us as precept is that this is a required rotation. So if you do miss something, you have to do a makeup. So on top of not coming, I have to fit you in on a day to do a makeup. And it's a very busy practice here, which I think you know. And I cut my patient load every time I know a student's coming, so I have a little bit of time to spend with you and teach. So I might cut 2 patients out or not double book something because I know you're coming. So suddenly, yeah, it's nice. I have a little extra time in the afternoon if you call in and don't come. But my intention was to be available to you as the learner and to be available. The other thing, sometimes I handpick a patient that I've seen when you're not here. And I say to that patient, would you mind coming in when my student's here? I think she or he would really benefit from talking to you. So last minute cancellations make this experience seem unimportant. And suddenly I have this patient here, or I haven't booked as many patients as I normally do, so my revenue goes down. So keeping to the schedule has great implications for our office.
Dr. Fornari, I had no idea that you were actually modifying your patient schedule for me. I really had no clue about that, and I feel extremely terrible about how I canceled on you. And I truly had no idea you were handpicking patients, and I can see how engaged you are in my learning, and I will definitely, moving forward, will not let this happen again. I really apologize.
I really appreciate you hearing what I'm saying and taking me seriously. I really know you seem very bright when you're here. You're engaged. It seems like you have a little bit of a time management issue from what I'm hearing with your work. I know I'm not a student at, the Zucker School of Medicine at this point, but I have been a student. And in terms of prioritizing, is there anybody at the school that you could speak to about time management that might be helpful to you? It's a little hard for me to do that since I don't know the curriculum as well as I should.
I think I just need to be more open, with my peers and see how people manage their week. I don't talk to that many people at school, and I think I could learn a lot from how people are managing their time. So I do have a couple friends that I can talk to and see how they work out their week schedule, and maybe I'm not doing enough work over the weekend, and even though I know what I'm supposed to be doing, and if I did that, maybe that would save me some time.
Okay, so use some resources at the school to help you because time management is going to be really important throughout your whole career. So use some resources at the school, be it a professional staff or your peers are a great option, I think also. I agree with you. I just want to go over, is there a day that works better for your schedule to come to ICE that we could really change the day so we don't have this issue of cancellation? Have you have any thoughts on that?
Yeah, since time management is an issue for me, so maybe if we schedule something for Fridays, I have sort of the week behind me, and I can focus on being there in your office and being more engaged. Maybe that, because the type of student I am, that may be helpful in the current situation that I'm in right now. I already feel like I'm behind the 8 ball, so Friday sessions may be easier for me. So I think that's a good
So we
solution.
could switch your day to Friday for your school, for your clinical time with me, and that's okay. And I'd like to see, really no cancellation other than a true emergency, which of course I'm understanding. And we could switch it to Friday. And the other thought I had would be also possibly a Monday, so it's the beginning of the week and maybe the work is not as built up. But I think this middle of the week crunch, Tuesday, Wednesday, Thursday, is probably not a good day for you to be coming. So we could switch to Fridays, and if I feel the patient load on a Friday afternoon is too low, perhaps we can consider Monday as another alternative to start the week with ICE. What would you think of that?
I think that's a great idea, Dr. Fornari. Thank you so much for taking the time to speak with me. I learned a lot about my time management and how much you are investing in my education, and I really appreciate it.
Okay, great. So I'm glad we had the opportunity to speak. I'd like to go back to see if anybody has any questions before we do the second scenario about this model and doing it this way. Okay, I see the question about collaborative team feedback. So the one thing we could have done in this scenario here is involve the office manager or the person who does the scheduling. Here we could have asked her to explain how the schedule was adjusted for the student because the doctor doesn't make his schedule per se. There's somebody in the office during scheduling. So certainly we could have involved the scheduler for that. The other situation is in terms of bringing in special patients. Also, we could have, he might have been involved with another physician who had a special patient in his office that said, I'd be great for the student to see this patient. So we could have involved another colleague in the office that was sharing the responsibility of the student. But they would both be there to give feedback as opposed to the usual where, well, Dr. So-and-so said he brought a special patient in for you and then you canceled. So that special patient really didn't understand why they had to come in and they wasted their time, even though we brought the patient in to see for the student to see them. And that would be hearsay versus bringing Dr. X in and having him explain, as I saw this patient, I rarely ever see this. I really wanted you as the student to see it, so I made special arrangements for the day you were supposed to be here, and then you canceled. Having the doctor who was directly involved in that come in and be involved in the feedback. So you don't want to gang up on the student and have a whole team of people there, but people who are directly involved in the issue, be it the office manager, the scheduler, another colleague in the office, which could be a physician, a nurse practitioner, a PA, anyone. If there's an issue, they should all be there for the discussion. So that would be an example. Does that answer your question? Any other thoughts on that collaborative feedback? Anything, Dr. Ahuja?
I just wanted to add that I think, Dr. Fornari, you're right about you don't want to have too many people because that could be very intimidating for the student. But when it comes from the voice of somebody who's affected or is involved in scheduling for you, I think that goes a long way. And I just want to add the day examples that we gave, the Monday and the Friday, that was just for the role play. In this student situation, ICE can be really any afternoon that the preceptor feels it's best.
I just want to say that the reason I said the office manager, because usually the people at the front desk are the brunt of the people that get the yelling at by a patient if they were brought in wrong. They may not say to the doctor, but they might say to the front desk person, he told me to come and now he doesn't need to see me because the student's not here. So the front desk person who gets the brunt of it might be good to have it feedback so she can explain the exact thing that happened with the patient versus I heard the patient was angry. I heard is not direct observation. So let's go on to the second role play and see if there's any questions, and let's go back to that collaborative feedback with the second role play as well. So, Taranjeet, you did a great job with that patient, really great job, unbelievable. You saw that the patient with the elevated liver enzymes, and what do you think's going on? What's your clinical impression? You picked up on her liver enzymes being elevated. What do you think?
So Dr. Fornari, thank you so much for letting me spend time with this patient. I know I was in there for more than what you were expecting, but I was actually able to find out from the patient that she's actually using more alcohol than what is recommended for daily use. So I have a feeling that this is all related to her alcohol intake.
So I see that you put social drinking then on your differential as one of the possible causes of her elevated liver enzymes. Do you feel you have accurate evidence of this social drinking?
I don't know. I just kind of asked, like, are you drinking every day? And she was like, yeah, I'm drinking, 5 beers every night. So, but it's always like, she's going to bars every night. So that's why I kind of put social drinking on there.
Right. So you don't feel she's like sitting in the street drinking alcohol.
Right. I think she just has a very active social life, and that's what it sounds like. But it's like every night. It's every night, 7 days a week.
So that definitely could impact her liver enzymes for sure. I noticed that you didn't do an in-depth, though, what I would call alcohol history in terms of our alcohol intake using the format. We heard about the school. We get these weekly announcements from the school, and we were informed that for an alcohol screening, Northwell's adopted a new tool called the Expert, and it's a standard alcohol screening tool where actually somebody gets a score that determines if they're at risk for alcohol abuse. Sounds like this person is, just anecdotally from what you said, but I didn't see you use the Esper tool in the room, and we heard about this tool, and it sounds like it's something that would be good for my office.
I guess I was just hesitant to use something that you weren't really familiar with. Espert is I think that's the one that's screening for brief intervention, referral, and treatment. Is that what you got in your?
Yes, we got an email about the Espert tool. Actually, they'd like our offices to adopt this tool as well. They're using it, I think, in emergency rooms right now, and they really would like some office practices to adopt this tool. So the Espert tool would have been a great tool, I think, to use on this patient to really get down and gain a lot of evidence about her drinking pattern, and then we could discuss her elevated liver enzymes in relation to that. So I was just wondering, what were your thoughts? You said you basically didn't do it because you didn't think it was part of my practice.
Yeah, I just thought you weren't familiar with it, and then you would,
right,
ask me how I did this. So I just kind of got a response from her.
Right, and it seems like she was talkative and told you about her alcohol intake, so she wasn't inhibited. But it would be important to use this tool, and if you felt uncomfortable, you could have, of course, always ask my permission to see what I think. But if it gives me better information about my patients, I certainly would be in favor of it. And it seems like she'd be an appropriate patient, instead of just doing a loose social history on drinking, to do the Espert form. I know sometimes I do a very abbreviated social history. I know at the school we teach an elaborate social history. I've seen what is taught there. But I think it's important you do the detailed social history and use the screening tools. So you mentioned you're worried how long you took in the room, but don't worry about that. It's really important for you to unveil something very significant, like a social history on drinking, abuse, perhaps, if that's how she scores, and give me that information. So I was wondering how you're going to remember the screening tools that you learned at school, because that's a concern. How would you remember that whole screening tool? I mean, maybe I'm just a little showing my age a little bit to remember all those questions. Maybe younger people could do that, but I was just concerned.
Yeah, I think I should just have easy access to these type of things that I learn at school on my phone and share them with you. And it sounds like you'd be interested in learning more and applying these tools to your practice. So I think that's great. That definitely motivates me to apply more of the knowledge I use that I learn at the school in your office, so I can have them easier accessible on my phone.
Right. Today, everything's available on the phone, so I'm sure that you could bring up the form to make sure you ask the right questions. And tools like this, I'm really happy to learn about and incorporate in my office. So I think what we want to do is have you share with me certain times things. And if you saw the patient had elevated liver enzymes, it definitely would prompt us to look at her, use of alcohol as a cause perhaps of this. So let's go back in and see the patient. And you picked up on the LFTs, and demo for me this alcohol screen. So bring it up on your phone and demo for that, so we can assess her intake very accurately and give her some very valuable feedback that will helpfully lower her LFTs if she's willing to limit her alcohol intake. What do you think about that?
I think that's a great idea. I'm actually excited to use the screen on the patient, so I think that's fantastic.
Okay, great. So I'll learn something by watching you do the Espert, and you'll practice the Espert, which is a great, learning situation for both of us. So let's go in and do that. Okay, thank you.
So this is Taranjeet again. I just wanted to also add that positive feedback is just as important as negative feedback. I don't think feedback should be labeled as time to discuss when something negative happens. Positive also is as important, and again, both being timely. Sometimes students see things that are written on their assessments that were completed by the preceptor, and there's no conversation that took place about that assessment that can really come off the student. It catches the student off guard. So if there is something that you plan to put in their student assessment, have this discussion with them, talk to them about it, so it's not news or a surprise to them when they read it on their student assessments. And I think that conversation goes a long way. When a preceptor sits you down and talks to you about something that happened, it definitely sticks with you rather than just reading something on an assessment that you received in your inbox in 145. So that's another thing I wanted to highlight, that students may not ask for feedback, but if you see the opportunity is right, please give them feedback. That is how they will grow to become the medical professionals that we want them to be, and move them a step closer to that. So take the opportunity when it arises and do it timely in the moment, and be encouraging and be their coach. This is what our role really is for them as preceptors.
So I just want to say that this important thing about positive, this particular student discovered the LFTs was related to alcohol. The feedback was to do more of a thorough social history to have more data, but the congratulating the student that they connected LFTs to alcohol intake and discovered very nicely if the patient was taking in a reasonable amount of alcohol, that's very positive. So that's the chance to provide positive collaborative feedback, and then to work towards what more can the student learn from this, and that is applying the ESPER tool that they practiced in class. So there's positive feedback, but then the other feedback is more of a, both of them are collaborative, but you saying to the student something they really did well, that you observed, you absolutely understood that LFTs possibly could be related to alcohol intake, and you pursued the social history on alcohol, is a very, very rewarding experience for the student to hear your positive feedback. So a lot of times we spend time only when something goes wrong, and we need to really balance that. Any questions? We actually took a little longer than I expected. So any questions that anybody would like to ask? Who's on the line? I see one question there. How do you as a coach deal with the insecurities of the sting of criticism that may come with the learner and prevent? So it goes back to this slide, who's ever asking this. How do I go back on the slides, Debbie? This slide is really important. So the insecurity comes from lack of confidence. So when you're building their ability and skill, you want to build confidence that this is part of this. I'm sorry. What? You want to build here in this model here that, does this work here? It does. Good. Oh, God. I'm trying to use a clicker here, but I'm trying to use this red thing. That you want to have the environment be safe, and you want to have the developmental trajectory. So the way you do this, you build confidence that the feedback is developmentally appropriate to the learner, and the environment where they're feeling the feedback, or hearing the feedback, I should say, is safe for them, where they feel comfortable in that learning environment. And in terms of our ICE and ACE program, and this is true in residency as well, the relationships are longitudinal. So the person giving feedback should not be somebody who they don't know, who they're uncomfortable. So let's say, for example, in an ICE or ACE office, a nurse practitioner or another physician saw somebody do something and they want to give them feedback, but the student is not comfortable with that learner. Having the person they're really trusting and comfortable with, maybe the other physician there as well, will provide a support system to help build their confidence as well as their ability and skill. So criticism has to be couched within a collaborative model that all of you are working on this, helping the person to see in the mirror and improve their performance. So it has to seem like a little bit of a seesaw effect here, that with self-assessment starting as the starting point, it will appear much less critical to the person because they're going to have the opportunity to say. So in the scenario we just did, for example, to say to the student, so what do you do when you want to do a very thorough alcohol history on a patient? Do you think just asking them how often they drink is enough? What are your thoughts on that? And then the student saying, no, I need to know the type of alcohol they drink. I need to know the size of the glasses that they drink. I need to know if it's every day. I need to know if they only drink in the evening, or do they need alcohol when they wake up in the morning to get started. All these questions I learned on this expert screening form. Oh, so you have a screening form for alcohol. Suddenly, the conversation is not telling the student they didn't do the alcohol history correctly. The student has identified all the things they missed. So they're not going to appear as a critical conversation. It's going to appear as a collaborative conversation. One of the issues that I did not bring up is that this takes a little bit of extra time with the learner. I can't say this is the same amount of time as you just being a cheerleader and saying, great job on identifying liver enzymes and the association with alcohol. Thanks for doing that. That's going to take much less time than what I'm describing. So you do need to allocate, instead of a minute, 2 to 3 minutes of feedback time, because you must give the opportunity for the person to look in the mirror. Right here, this looking in the mirror thing is really important, because they're going to put on the table most things you want to talk about. And that will take away that bite, that sting of criticism that you talk about, that's very, very disheartening to any learner. So it's a great question that was asked. Any last questions before we end? I really want to thank everybody that came on. I do have something really important to say, so I hope people are still here. We are having a November 30th journal club on feedback, where we're reviewing 2 articles, both from 2017, by a very prominent med ed person from Boston University, is the lead author on both articles. And she did a study, 2 different studies, related to feedback to learners. Both articles are excellent related to feedback. I think you'll learn a lot more also about feedback. It will be additive to what we discussed tonight, a little bit thinking about learning environments and feedback. So that's November 30th from 12 to 1. You must pre-register to get the link to the webinar and to get the 2 articles to read. And this will be coming from Dr. Ahuja. The flyer already has gone out once, if not twice, so you might have received it, but I'm not sure if everybody looked at it, but I'm heightening your awareness of it. And Dr. Ahuja will be sending the flyer out specifically to ICE and ACE preceptors again. I guarantee you this will be an informative hour of your time on Thursday, November 30th. So look for that flyer if you don't have it already.
Thank you all again for joining us tonight. If you have any other topics that you think would be great for webinars, please email me. And have a happy Thanksgiving and a great week.
Oh, right. I forgot to say happy Thanksgiving and enjoy your holiday.